Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we are doing a little bit of a series on our men's health, and we have advances in treatment for prostate. I have Dr. Lwin with me here today. He is a physician with Arizona Urology Specialists. He is a member of the American Urological Association, the Western section of the AUA, and the Arizona Urological Society. He received his medical degree from Southern Illinois University School of Medicine. And during his residency with the University of Arizona, Dr. Lwin received the Dr. George Drack Award, presented for those with extraordinary compassion in urologic care. He specializes in benign prostatic hyperplasia, prostate cancer, and general urology, and more. Dr. Lwin, I know this is the first time you've spoken for us. Thank you for joining us today.
Thanks for having me.
So we have an in-person audience along with an audience that is online. So please, if you've got any questions, our online audience, you can leave those in the chat for after the presentation. So I'm going to go ahead and hand this over to you, Dr. Lwin, and you should be all set to go.
All right. Well, thank you. Do I need to unmute?
You're good.
I'm good. Awesome. All right. So yeah, thanks for the introduction. I'm Lwin, one of the urologists here at TMC. I also work over at Arizona Urology Specialists. So thanks for coming. Thanks for giving me your time, and we'll talk today about BPH. As Maya said, just a little bit about myself. I was born and raised in Illinois. Did a lot of my schooling there. Came here to the university for my urology training, and didn't want to go back to those winters, so stayed out here. Okay, so today what we're going to be covering is just kind of a general overview of the prostate, like what is it, and potential prostatic issues that guys will be experiencing. We're obviously talking today about BPH, so we'll also be talking about what that is, kind of, how that could affect you, and if it does affect you, potential treatment options, and there's a lot of them. So we'll kind of go from kind of the ground up of what the treatment options for BPH are. So overview of the prostate. What exactly is the prostate? It's a small gland. It sits between your bladder and your, so the bladder is here, and then the gland sits right here. Think of that as a donut, and we'll get back to that analogy of the donut, okay? You pee out of the hole of the donut, which is the urethra there. The urethra continues, you urinate out here. Here is your pelvic floor muscles right here, and then this is your rectum, all right? So a difficult concept is that it surrounds the urethra, but part of the urethra goes through that donut hole like I was talking about. So what does the prostate do exactly? It makes some of that fluid in your semen during ejaculation, and then also it converts one of your testosterone into a more potent form of testosterone called DHT, okay? In your 20s, it grows to its normal size, and then unfortunately for us guys, it starts to grow again in your mid-40s, and as you get older, that donut, so to speak, just gets larger and larger. All right. So what can happen in the prostate? These are probably three of the most common issues that we see. Obviously today we're talking about BPH, and we'll get into that in a little bit, but that's kind of just the prostate, that donut growing over time as you get older. And unfortunately, there's not a whole lot we can do about it too, okay? Prostatitis is more inflammation of the prostate. There can get bacteria, there can be non-bacterial inflammations of the prostate as well, but that's going to be, pain when you, like let's say you're an avid bike rider or something like that, that pain, that saddle area, that can be prostatitis, okay? And then obviously prostate cancer, very common in men. It's the second most common cancer in men. So something that guys have to think about. And, from ages 55 to 69, we should really be trying to do at least a blood test every year, that PSA that you guys probably have heard of. And after ages 69, 70 and beyond, it's kind of a decision with you and your primary care or your urologist if you have one. Okay. So going back to BPH, what does BPH stand for? The B is benign, meaning not cancerous. Okay. P is for prostate, obviously, and then H is it's for hyperplasia. Hyperplasia is just growth of that prostate, that prostatic gland. All right, but just for ease, we call it BPH. This BPH can, like I said, grow and lead to blockage of your bladder, and that can also cause lower urinary tract symptoms, or what we call LUTs in the urology world. And we'll get to those more specifically, what those symptoms could be that you guys could potentially be experiencing. So a lot of questions I get are BPH and prostate cancer. Is there a relationship between the two? So I want to make this very clear that BPH does not mean you have prostate cancer or anything like that. It is not prostate cancer. Again, that B in BPH is benign, which means not cancerous. Okay. It does not cause prostate cancer either. This is very common in men. And so I don't want you guys to leave here thinking that it will cause prostate cancer. The confusing part is that prostate cancer and BPH can have similar symptoms. Generally speaking, prostate cancer, at least when we detect it, in that age range of 55 to 69, most guys don't even know it's like, they don't have any symptoms. They just come for their yearly check. We get some blood work, and it's a little bit high or something. But BPH, and like I said, we'll talk about the urinary symptoms here in a little bit, but those symptoms can be similar. It can also coexist with prostate cancer, meaning you could have these urinary symptoms, but also have prostate cancer at the same time. So as a urologist, what I'm trying to figure out is do you have cancer? Do you not have cancer? And if not, let's say it's not cancerous, but you have urination issues, then we talk about, either medications or a procedure to help men urinate. And then the last part here is about that PSA. The PSA, like I said, it's a blood test screening for prostate cancer. And it doesn't mean that, just because one is high, you have BPH or anything, and vice versa. A normal versus enlarged prostate. I like to think of this in terms, it's all plumbing, okay? So the bladder is the pump, okay? So you have the pump squeezing, and then your prostate sits right below there like we talked about. And again, think of the prostate as a donut. So as you get older, that donut gets larger, that hole gets smaller. So the pump has to work harder, okay? Over time, sure, like the pump could fail and everything, and we'll talk about the symptoms on the next slide here. But that's how, like this overgrowth here can really cause just difficulty urinating. Another important point to bring up is the fact that the size of the prostate, the size of the donut, doesn't always correlate with symptoms. In my practice, I have guys that have just pretty small prostates, but they have really bad symptoms. And the other way too, where I have patients with like a prostate that's 4 times the size of normal, and they don't have any symptoms. So just because you have a big prostate doesn't mean you'll be having symptoms or anything like that. But generally speaking, they do correlate in a way. So what are the symptoms? How do you know if you have BPH or not? Some of those urinary symptoms we're talking about. For me, I like to kind of think of it, going back to that plumbing situation again, as like symptoms that block, or what I like to call obstructive symptoms, and then the other side is called irritative symptoms. So the blockage symptoms are going to be, think of like a water hose, for example, like a weak stream when you urinate. You really have to push to urinate. You don't empty your bladder that well, or the urinary stream cuts on and off, okay? Those are what I like to call obstructive symptoms. The irritative symptoms are frequency and urgency. I go a lot during the day. I'm going every like 15, 30 minutes. Or when I have to go, I have to go. I'm watching TV and I can't make it to the commercial. I have to go now. Or, you know, if you're traveling, I have to pull off to the side of the road or something. Those are irritative symptoms. And then at night, you can also have, you know, what we call nocturia, where you're going a lot at night. For sure, the BPH can cause more of those obstructive symptoms. The irritative symptoms, the frequency, urgency, that can be from the bladder. It could be a pump issue where the bladder is squeezing a little too much, something that you've probably heard on commercials like overactive bladder. But it also could be a prostatic issue, meaning that you're not emptying your bladder because of a big prostate. The way I like to think about this is if your bladder is if it's a gas tank, you're going from full to half full, full to half full, meaning that you're going to go to the gas station more often, right? But if you empty your bladder, because if you have, you know, if you're not blocked up by your prostate, you'll be going less, and that frequency can diminish over time. And at night, kind of the same thing. If you're not emptying your bladder at night, you know, before you go to bed, you're going to be certainly getting up in the middle of the night more often and going. So, you know, this is something that's very common in men. Almost, you know, up to 95% of men with moderate symptoms that are unhappy and don't want to spend the rest of their lives with these symptoms. About half of men say that BPH interferes with some aspect of their normal life. Another, you know, 49% say that they experience sexual problems associated with those lower urinary tract symptoms, those symptoms that I just talked about, the obstructive and irritative voiding symptoms. And BPH also affects men's partners' quality of life too, the daily routines and the relationships as well. So who can get it? Most common problem, prostate problem for men age 50 and above. And as we get older, we can see that, you know, 60, half of men are kind of affected by this. 85, 90% of men are affected by this. You know, in 2010, 14 million men saying that they have, you know, issues urinating in some degree. Things that, you know, that are related to BPH, you know, a lot of guys asking like, well, what could I have done to, you know, prevent this sort of thing? Unfortunately, there's not a whole lot of links other than, you know, just your obesity and body mass index or your BMI and lack of exercise. To be quite honest, I don't think that even this population could have really done anything about it. I think their prostate was going to grow regardless. A lot of it has to do with genetics as well. I've noticed that, you know, a lot of my guys in my clinic are like, hey, my dad had prostate issues. He didn't really tell me about it, but, you know, I think he definitely had issues urinating. And now, you know, in my 50s, 60s, I'm also getting those things. And so, you know, we explore those symptoms and talk about it. So how is it diagnosed? So this is a, you know, important question that varies amongst urologists. You know, in my practice, I've moved away a little bit from the rectal exam, to be quite honest, and that makes guys happy. You know, I don't enjoy doing it. You guys don't enjoy getting it. And the thing is, you know, going back to those pictures, the rectum, here, I'll go back. So when I put my finger back there, I can only feel a small percentage of your prostate. I don't think it's a great exam. It's a good exam for feeling for cancers, but even then there's, you know, it's 2022, there's better technologies for that, like such as an MRI. But I only feel a little bit of it. So I kind of have to extrapolate, like, okay, I'm feeling 20% of it. I'm trying to imagine that the 80% rest of the prostate. So there's still some urologists that do this, and I don't fault them or anything like that. It's a quick and easy way to figure out like at least a rough estimate of your prostate size, but there are certainly way more diagnostic tools that we can find for prostate size. But what I personally do, I use an ultrasound. So I put a larger finger up there, unfortunately. But then I can actually measure the size of your prostate. Or, you know, like let's say you guys have had a CT scan for something, I could just easily measure it without putting a finger back there or anything like that. So I do feel like that understanding how big that donut is is important for treating for BPH. The other test I like to do is this urinary flow and how much you're retaining. This is, objective data that I get. You guys just urinate into a fancy toilet, and I get to see how fast you're urinating, the velocity of that. I get to see a curve as far as it should be looking like a bell curve, but sometimes, or often I should say, men with BPH kind of have like a flat curve because they just can't mount a good stream. And then the last thing I like to get is something called a post-void residual or a post-void urine. This is kind of the volume you have after you urinate to make sure you're not retaining onto urine, because that's what really can, be life threatening or harmful to your life. Because if you're holding on to, let's say, half a liter of urine at all times because you can't urinate all that out, you can have infections that can happen, blood in the urine, stones can form in the bladder stones. And then if it gets really bad, I've seen patients that have had over, 3 to 5 liters of urine in their bladder, and that can ultimately affect their kidneys. Okay. So I think that's very important to get here too. This part is just kind of what you guys tell us. There's multiple different ways to look at it, but there's these two are all these three are questionnaires basically of how well is the patient doing symptomatically. And so this part is, what the patient tells us and what they report to us. So this is a combination of these two is what we use subjective data and objective data to make a diagnosis. So treatment options. So on here, there's urologists have been working for hundreds of years trying to figure this out. Okay, and I think we're getting pretty good at it. But there's a spectrum of invasiveness of surgery or of treatment. Excuse me. It can be surgical, but it also could just be modifying what you're doing at night and everything as well. So we'll talk. We're going to go from least invasive to most invasive on this slide. And there's a few things missing in here that I'll also tell you about that I use in my practice as well. So one quick note is that there's, you see on TV, at gas stations, there's all these natural supplements to help men urinate. There's no long-term or long-term studies or anything like that show that these help. I think the biggest offender here is the saw palmetto. There's maybe 1 or 2 very small and limited studies that show that does help. But when they took a big sample size and looked at it, wasn't any better than placebo. So, when patients ask me about that, I tell them I think they're wasting their money. But if they do tell me that they are feeling symptom relief, I just say, have at it. So the first thing is what we call watchful waiting. We just kind of, that's kind of more of your behavioral modifications. Okay. So what is it? It involves modifying your lifestyle and adjusting your diet and your fluid intake and seeing if that helps with urination. I tell my guys that, that they don't want medication and they don't want any sort of surgery. What I'll tell them is that at night, I would say try to pee twice. So right before you're going to go to bed, urinate, wait, 10 minutes, do your nightly routine, brush your teeth, whatever. And even if you don't feel like it, urinate again. Really empty that bladder. So that way, you'll have the longest time before your bladder fills up. Okay. As far as dietary or fluid restrictions, I tell them normally, after dinner, around 6, maybe 7, no more fluids. And then my guys that have a lot of swelling in their feet, I tell them to start raising their feet as well, because your blood return will get back quicker and you'll make that urine before you go to bed. And that way you won't get up at night. And then obviously, caffeine, alcohol can irritate the bladder too, and that can really get you going at night. And so those are kind of the mainstays of watchful waiting. Side effects, I mean, it's not going to get any better, unfortunately. You know, the prostate at that, if you're not going to do anything about it, it's going to stay that way. So you can kind of just curb your symptoms a little bit as you wait. And then your prostate will most likely continue to grow, and you'll have reduced options as you get older. You may not be a good surgical candidate anymore, you know, if you're in your 90s and that's how you want to wait. Okay. Once we, you know, if you want to do something about it, the least invasive thing is probably the medications. There's two of them. There's one that I favor and the one that I really don't like to give just because of the side effects, and we'll get to that. But the first one is called alpha blockers. That's a drug class. The most common of them being tamsulosin or Flomax. Other cousins of that include alfuzosin or silodosin. I think they're called Rapaflo. You've probably heard of that maybe before, but certainly on the commercials, Flomax is what you're seeing the most of. So how does this work? It's a medication, and if, again, think about that donut analogy, it makes that donut hole larger. It relaxes the musculature of the prostate so you can have a better flow, okay? Side effects of that medication, you take it once a day. I'd say to just take it at night just in case you have side effects. But the side effects include low blood pressure or a drop in blood pressure, dizziness and fainting because of that drop in blood pressure, headaches, fatigue, and then there's one listed not on here is what we call dry ejaculations or retrograde ejaculation. Basically, instead of the semen going forward and you expelling it out, it goes back into the bladder and you urinate it out eventually. Not harmful to the body or anything, but just, you know, it's different for guys, and some guys, if they don't know about it, they are very surprised and are alarmed. So, you know, this is one of the medications, probably the most common one that I would prefer. And, you know, let's say you do take this and you're happy with where you're urinating, that's where we stop. And I think it's a very good option. The second medication is a drug class called 5-alpha reductase inhibitors. That is a drug class. The medications will be called finasteride. How this helps is this shrinks the donut. This is the one medication that shrinks the donut. And what it does is, you know, I was telling you one of the functions of the prostate was to convert testosterone into a more potent form. This stops that conversion, and by doing so, it shrinks the prostate over time. We're talking about 3 to 6 months minimum, okay? So it does take a little bit of time for it to work. Some guys that have BPH that also have blood in the urine, it can help with blood in the urine. That's one area where I definitely will try to prescribe finasteride. However, I normally stay away from this medication because of the side effects. There's a lot of side effects we don't know about either. And luckily, you know, when I was in medical school, the urologist there was really into the research of that. And so there's something called post-finasteride syndrome. We just don't know a whole lot about it, but those are lingering side effects that happen even after stopping the medication. So that's just why I don't generally like to give this medication, especially because there are other options to do other than medications. But side effects that we do know about: erectile dysfunction, lowered sexual drive or like a lowered libido, ejaculatory dysfunction, and then breast enlargement. The things that we don't know about, there's a lot of new studies that show that it could mess with, or it could alter your cognition. So potential like depression, just you're not as mentally sharp as you were. And those are things that guys have noticed on this medication, and we're still looking into that. As we go up that spectrum of invasiveness, this is probably, we now get into like what we call clinic-based procedures. So there's two main clinic-based procedures. The first one is called Resume. It's a water vapor therapy. I used to do what we're going to talk about next, but I've replaced that with this just because I think it's a little bit more natural and a little bit better for you. And my patients that have undergone Resume have actually liked it a lot. So this is what I'm doing now more in the office. If you want something that is minimally invasive and not wanting to be done in the operating room. So what exactly is this? It is basically putting water vapor or steam into the prostate. I inject that in the office, and over time, in the course of about 2 to 3 months, it shrinks the prostate. Okay. It's a relatively new technology, and so looking at the long-term data, how well does this work? Years from now. The one study that we have is at 5 years, about a 4.4% surgical retreatment rate, meaning you need another procedure 4% of the time. So that means 96% of the time, or 93 or 95.6% of the time, you don't need anything, and most guys do very well with this. Side effects. A lot of the side effects, because I inject that steam or water vapor into the prostate has to heal, and it takes about 2 to 3 months. So, I would say most of my patients that I do this procedure on, they have side effects for about 2 to 4 weeks. In very rare cases, it can last up to 1 to 2 months. And then and luckily I haven't had this, but I've heard some patients having some side effects maybe up at 3 months, just because their body's just a little bit slow to heal. But what do they complain about? I think the main complaints are frequent urination, painful urination, and then urgency. When they have to go, they have to go. But other possibilities include blood in the urine, blood in the semen, your ejaculatory volume decreased, potential urinary tract infection, and then there's that urgency we talked about. I would say it probably happens in about 10 to 15% of my patients, and that's what is reflected also in the long-term studies that we've had for Resume. So again, it's how does it work? Let's see if this video plays.
Resume water vapor therapy is a non-surgical treatment for BPH. Resume uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Resume is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and is clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Resume therapy lets you quickly return to normal activities. Talk to your doctor about Resume if you are no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life, or you don't want to have surgery or get an implant.
So let's see here. So looking at just patient satisfaction scores, 97% of patients would recommend this to a friend, meaning that it does work, and especially for a minimally invasive procedure, very effective. And I think this is a testimonial that we have here that we can kind of listen to, but he's basically saying that he had a very good experience with it, and that it just it works and is effective.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first started Resume when I was researching enlarged prostate and procedures to repair it. And Resume was one of them. the more I researched the Zoom, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Zoom procedure was very good. After the procedure, I was a little warm, a little tired, and the next day I felt fairly good, was able to get up and get around.
Since Joe's resumed procedure, we're able to spend more quality time together, fewer interruptions, and we're just happier as a couple. The resumed treatment has made a very big difference in our life.
All right. So the other clinic-based procedure is something called well, I guess let me back up and say one more thing about Resume is that if patients do want to do it in the operating room, I do give them that option. So, you don't want a scope, in your urethra during the office. I get it. I completely understand that. So if you're really adamant about having it in the operating room, I think it's also reasonable. And I do it in the OR setting as well, just as an outpatient procedure. The next office-based procedure is something called Urolift or prostatic urethral lift. This is something that is more, it's like a permanent suture. It's a metallic little tab that holds the prostate apart. So the way I think about this is if you have a window closed with curtains, I'm going to use like a little prostatic, a metallic like suture to kind of pull those curtains aside, so to speak, so you can see out the window and get better flow. Okay. I used to do this procedure. I've replaced it with Resume just because I do think it does work a little bit better. I still do think that this is a good option. So, if you've had this in the past or anything like that, I'm never going to talk you out of it or anything. But in my practice, I do think that my patients are happier with Resume. Side effects. The side effects from this onward are all going to be somewhat similar. But painful or frequent urination, blood in the urine. You could have pain down below as well. Those, like I was saying, it's a metallic suture. So that urine, when it contacts the stone over a long time, especially, this suture has to be in your body for the rest of your life. If it ever moves or anything like that, and it comes into contact with urine, a stone can form on that, and that can cause more symptoms as well. The retreatment rates are a little bit higher as well at 5%. I think this, like I was saying, this is a good option, but the prostate configuration has to be right. There's a few people, like a few urologists, that they Urolift everything. I don't think that's the way to go. I think your urologist should really tailor your prostatic surgery or procedure to your prostate. I don't think there's not one procedure that does it all. The other thing is let's say this works for a few years and then now it's not working. Your prostate is growing again and everything. It's difficult to get those tabs out of there. So that's another reason I've kind of shifted away from this, and I do Resume. The nice part about Resume is also that, let's say you get some relief after a few years and you want more relief. I can either A, do it again, or B, do something else. It doesn't close any doors. That's relatively true for this, but like I said, getting those metallic sutures is a little bit more difficult to do so, especially if they move and everything. When I was training, one of my bosses, he's been doing this for about 10 years, and he started noticing that those tabs start moving after about 10 years. And so he started noticing his patients having problems. So that's why, it's good, because this is also relatively new, not as new as Resume, but we just have started noticing that in the 10-year data. So we're waiting on that all to be published. The next sort of surgeries are kind of focused on opening that donut hole again. These will be now more in the operative setting, meaning you'll have to undergo general anesthesia. One of them is called green light laser therapy. This is using a laser to vaporize the prostate tissue and make that donut hole larger. Side effects, again, will be very similar, but you'll have painful urination, urinary tract infections, bleeding, incontinence, scarring of the urethra, dry orgasm. I would say that these exist, probably less than 10% for all of them. Retreatment rates are good too. After 5 years, about 4% or 5%, excuse me. How does this work? Well, this uses a laser. Let's see if we can get here, maybe.
That one, yeah.
Yeah.
And then, yeah.
Oh. Let's see if this works here.
Are this issues for your woman? Well, you should.
Not that one. Or is this an ad? I think this is an ad.
Because this issue.
Here we go. So, but yeah, you see that how they use that laser to just kind of shave away that prostate and make that channel larger. And so the bladder has an easier time pumping against a lower resistance to empty the bladder better and for the patient to have a better stream. So that's green light laser therapy. I personally don't do this. I think it's an okay procedure. I do think that what I'll talk about next, that's one of the procedures I do. For me, I don't like this because you're lasering the prostate, but you don't really have any landmarks, no anatomical landmarks of how big to make that prostate. So that's why I personally just don't do this procedure. But it does have good effects, and we've looked at the data about that too. I will say that this is one of the technologies that if you're on like anticoagulation or on any sort of blood thinners, this is one of the approved ones because as you're vaporizing the tissue, you're also like sealing those blood vessels, so there is theoretically less bleeding. The next one is transurethral resection of the prostate, or TURP. This is what urologists have been doing for 50 plus years. I think it's been around because it works. This is one of the procedures that I do as well. You basically use a heated wire to cut tissue from the prostate and make that donut hole larger. Side effects are very similar to all the other things, but painful urination, urinary tract infections, bleeding, scarring of the urethra, dry orgasm, erectile dysfunction. Surgical retreatment rate, I don't know if it's even that high, to be quite honest, at 5 years, just because there's way more data now. And there's newer technologies in the TURP world for stopping bleeding or anything like that. When urologists started doing TURP 50 plus years ago, the technique was significantly different. And we have techniques now that decrease bleeding as well as any sort of other like side effects on your body. My patients that have TURP, would say they have a catheter after the procedure for about 1 to 3 days. I would say generally speaking, probably 80% or 80 to 90% of the patients go home the same day as well. But you do have to undergo general anesthesia, just like the green light procedure. And I do think this is a good procedure. There's one procedure in here that isn't mentioned, and it's probably something that I specialize in. It's called HoLEP, or holmium laser enucleation of the prostate. It's been around for about 20 years. It's just a very difficult technique. So that's why urologists have not really adopted it. Luckily here in Arizona and in Tucson specifically, this is probably one of the areas that has the most urologists that actually do this procedure. And I was fortunate to learn it here at the university as well, but it's called HoLEP, or HoLEP, or holmium laser enucleation of the prostate. But the way I think about that procedure is think of that prostate now as an orange, not a donut. I take a laser and I remove the fruit from the rind of the prostate. To me, it's the most complete TURP or any other of these other procedures that you can do, because I'm really just shelling out your entire prostate, okay? It's also a procedure where you're just, an outpatient procedure. Surgery usually takes about like an hour and a half to do. You have a catheter for less than 24 hours. Retreatment rates for that less than 1%, just because it's the most complete prostate removal you can do, shy of removing the entire prostate for prostate cancer. Side effects are the same. The HoLEP, just like the green light, is one of the procedures that is approved if you're on blood thinners or anything like that, just because that plane between the fruit and the rind, so to speak, is not very bloody. So patients do really well. I don't even discharge patients on pain medications after that surgery, just because no one complains of pain. Things to expect, like the side effects for that procedure, I would say the two main ones include dry ejaculate, and then the other being temporary leakage of urine. Because I'm removing so much, your muscles are the ones that are your muscles are what really come in, front and center after that catheter comes out. So you just have to get used to urinating like you were 18 again, and that takes on average about 1 to 2 months. Okay. The last one is prostatectomy. This is also a little bit more. I mean, urologists don't really do this a whole lot anymore, mainly because that HoLEP procedure I was just discussing has replaced this. It's size independent, meaning that you can have a small prostate, a big prostate. It works for all sizes of prostates. But in 2022, there's still some urologists that don't know how to do that HoLEP procedure. They still do this. There's a few ways to do it, but I would I would say more contemporary urologists are doing this robotically now, just like how if you had to get your prostate removed for prostate cancer, and they're doing it as like either a one-day procedure or an outpatient type of procedure. But it removes the inner prostate via either an incision of the lower abdominal area. So, it's a little bit more invasive because the surgeon has to go inside your body, so to speak. There are cuts on your body, whereas all the other ones are what we call transurethral, or through the urethra. No cuts on your body. The big things here: bleeding, infection, possible, hospital stay, like I was saying. But if you look at the retreatment rates, because you're removing more, it's less of a retreatment rate through 5 years. So there's a few ways to do it, but now it's oftentimes they're just doing this robotically. So insurance coverage, it is your responsibility to figure out, what insurance options, or what your insurance is opting to cover, what they're not opting to cover. And I think it's important for the patients to know that, because, I do get asked questions like, how much is this going to cost for me? I'm just like, I don't know. Every insurance is a little bit different. So, but we can easily work with you to figure that out. So in summary, we talked about the prostate. How does it work? Like I was telling you, just think of that. It's thinking of it in terms of plumbing, and how that bladder is the pump and the prostate sits right below it. It's a donut. Okay. BPH, it's not cancerous. It is just an enlarged prostate. Just has to do with age, unfortunately. Treatment options, we've talked about a lot of them. There's watchful waiting, behavioral modifications, dietary restrictions. The first line therapies, I would say that the medications are really the first line therapy. And then I would group Resume, that Urolift, and all the other surgical procedures we talked about under surgery of some sort. I would think really first line therapy is medication only, just because you're not undergoing a procedure of any sort. And then, so if this is something that speaks to you, that you're going through, talk to your doctor, talk to your primary care doctor, talk to your urologist if you have one. Primary care can always refer you to myself or just any other urologist in town. And then we can kind of determine, where you're at in that spectrum, and kind of go from there. So yeah, thank you for having me. Thanks for coming, sharing your time, and we'll open it up to some questions.
Thank you, Dr. Lwin. I do have a question for you that came in. Can you advise what your opinion would be of a prostatic artery embolization compared to therapies that you discussed?
That's a great question. It's a really advanced question too. So prostatic artery embolization was not listed on there because it is not part of at least what the American Urologic Association considers to be a first line or a surgical procedure. Basically, the idea of the prostatic artery embolization is it's a procedure that the interventional radiologist would do. But basically, they're embolizing or stopping the blood flow to the prostate. The idea behind that is if the prostate doesn't have any blood flow, it'll shrink over time. And so this is prostatic artery embolization, or let's call it PAE, is relatively new. I would say probably in the past 5, at most 10 years. It's very popular in Europe. And in the European Urology Association, that's part of their guidelines. That is an option. When the American Urologic Association looks at it and looks at the data, it does not approve it yet. It says that it is more of an experimental procedure still. Anecdotally, I will say that I've had a few guys, I could probably count 5, who have had that procedure. And some guys have done really well. And some, like 2 of those guys did really well. 3 of them needed some sort of retreatment. And I think what happened for the guys that needed retreatment was that, if you think of that prostate again as a donut and you're peeing out of the hole of the donut, it treated one side of the prostate. So one of those lobes, so to speak, got treated. And I'm looking in there and I'm just like, wow, like it really did work. If only it worked for the other side. So what I have to end up doing is some sort of laser procedure or something to kind of treat the other side and kind of make that channel a little bit larger. So right now, at least, for me, I don't think that it is, recommended quite yet. I think more long-term studies need to be looked at. I will say that, for my guys that have a lot of recurrent blood in the urine or recurrent hematuria, I do recommend that just to at least stop the blood in the urine.
Okay. I had another question here that came in that is asking if they had a friend that had their prostate removed. Is that something that you do for BPH?
So generally speaking, no. Removing your prostate, that's kind of, I hesitate just because removing your prostate, there's many definitions for that, right? And so removing the entire prostate, when I use the analogy of an orange, the fruit and the rind, that is generally speaking for prostate cancer. You need to remove all of the prostate because the prostate cancer can grow out of it and you don't know where exactly it is always. When we talk about BPH and treatments for BPH, we generally do not remove the entire prostate just because removing the entire prostate is a much larger procedure and is not needed. The treatment options we discussed today, either the ones in the office or in the operating room under general anesthesia, those are the ones that are. So yes, technically I'm removing some of your prostate, but not the entire thing.
Okay. And can you remind us which procedures then would you be doing in the office? Is Resume in the office or is that, okay, like that's which ones?
Great follow-up question. So personally, what I do, I either do the Resume procedure. That can be done in the office. I would say a majority of my patients go for that. But like I said, I can do it in the operating room if, for patient preference or if you're just not going to tolerate it well. I also do the TURP, that roto-rooter, so to speak. And then I also do that HoLEP procedure, which is the laser and removing, the fruit from the rind. Okay. A few of my partners do, I would say a majority of my partners still do the Urolift procedure. And they also do that in office. I think there's probably 1 urologist in town that does green light, maybe 2. And then, yeah, that's basically it.
Okay, HoLEP that you do a lot of, you do in the office? You tend to
No,
do-
that is, sorry, going back to your question. So yeah,
Okay.
transurethral resection of the prostate, or TURP, that's in the operating room. And
Okay.
then HoLEP is also in the operating room under general.
Okay, great.
Both as
So-
outpatient procedures.
I did want to put up, in case anybody is interested in an appointment, that they can reach you at 520-795-5830. Also, would it be safer to do any of those procedures in the hospital with sedation, or is that not necessarily an issue for these procedures?
Safety goes, I mean, if you're on a lot of blood thinners, anticoagulation, you have a lot of issues, cardiovascular issues. Let's say you see a cardiologist because you have a cardiac, you've had a heart attack before. I would try to push you to do something that isn't as invasive, just because undergoing general anesthesia is a risk, so that could put stress on your heart, and you could have, not from the surgery, but from anesthesia, other complications. So if the patient isn't a good surgical candidate, I try to at least try to push them towards either a Urolift or a resume.
Okay. Okay, I've got, a couple more questions that have come in on the PAE, which was the prostatic artery embolization for everybody. Is that FDA approved?
Not FDA approved, at least, as of a year ago. Like I said, if you go to Europe, a lot of the European countries are doing that, but not here in the States yet.
Okay. And if somebody had, what would you recommend for somebody if they already had a Urolift, but their BPH symptoms have returned?
Yeah, that's a great question too. I see a lot of that as one of the urologists here that does HoLEP. So I think you need to do something a little bit more invasive. I would have to I think it's prudent to evaluate the prostate, because the thing is the Urolift may fail if your prostate is too large and your urologist never really measured your prostate. Generally speaking, though, for me, I would probably say more often than not laser those clips out and the whole prostate, that HoLEP procedure. But I have done some of the roto-rooter, the TURP, so to speak, to kind of make a larger channel.
Okay, great.
I don't think Urolift is the right answer again. Don't do the same.
Okay, thank you. I so appreciate you being here with us today. I want to thank you from our online audience. I'm going to go ahead and sign off with them, and you can continue on in the room. Thank you.
Okay, thank you. Thank you for having me.
Thank you all for being here today. We look forward to seeing you at our next presentation, which will be on Thursday. On Thursday, we have how to improve our gut health and boost immunity at 10 a.m. on Thursday, September 22nd. We'll see you then. Thank you.